40% had MI, 18.6% had a stroke, and 46% have CV death. So that means all the patients who are actually stable are not actually stable. If you see of the 20% patients who experienced an event over 3 years, of the patients who had actually stable angina, 40% patients had an MI over 3 years, 18% had stroke, and 40% had cardiovascular death. The myth of stable coronary artery disease. Patients with chronic CAD are not necessarily stable. Be aware of the patient's residual risk even if they appear stable and are feeling well. Clinical inertia can result in recurring events. Stable CAD is now no more stable, and therefore ESC 2009, European Society of Cardiology 2019, has shared stable angina, new heart failure symptoms, and suspected CAD as chronic syndrome, chronic coronary syndrome, or something like that. So clinical data, what are the optimal medical therapy? Because we are all clinicians, and therefore we should know what is optimal medical therapy. The 4 pillars of chronic CAD management is, of course, lipid lowering, statins, blood pressure control, blood glucose control, and other the anti-anginals which we are giving, like sorbitrate or like nicurendil or ranolazine. Other than that, we have anti-thrombotic protection. So what we are going to talk about the anti-thrombotic, how much is aspirin, how much is clopidogrel, and whether do we need to add something on the top of that. Does this anti-thrombotic regimen provides optimal control or not? So let us discuss first pillar of chronic CAD, which is aspirin dual antiplatelet. Does this antithrombotic Charishma trial DAPT equivalent to aspirin alone in cardiovascular disease? Charishma trial has shown that DAPT dual antiplatelet agents equivalent to aspirin alone in cardiovascular disease. There is no need to add this that we don't need to have another. Picagus trial, ticagrelor reduces non-fatal CV events but increases major bleeding in patients with, that means ticagrelor is also not so important, it can cause major bleeding issues. So what are the current unmet needs from single antiplatelet and dual antiplatelet therapy? So MACE reduction is significant, but no significant benefit in CV reduction, no significant benefit in all-cause mortality, and no significant benefit in major adverse limb events. Optimization, what do we need for the optimization of vascular protection? Dual pathway inhibition is important. This is a new concept which is coming up. That means antiplatelets are not enough. That means if you add clopidogrel or ticagrelor over aspirin, it does not cause major protection. So dual inhibition pathway, which I'm going to tell you, is actually platelet activation and also because there is a persistent thrombin generation in chronic CAD. That's why we can have unstable events in a chronic patients, because there is a persistent thrombin generation in chronic CAD, and therefore we need to block that also. So dual pathway inhibition therapy, that means not only platelet aggregation, but we need an anticoagulant other than we need anticoagulant other than platelet aggregation. So this is a COMPASS trial, a dual pathway inhibition approach, which was a study published in New England Journal of Medicine, Journal of Cardiovascular Therapy, and the objective was to determine the efficacy and safety of rivaroxaban, low-dose rivaroxaban plus aspirin or aspirin alone for reducing the risk of MI and cardiovascular death in CAD or PAD. So this was actually a very important trial. This was actually a very important COMPASS, a dual pathway inhibition approach, a very important trial and follow-up of 23 months at early termination of a study. And this has shown that antithrombotic investigation was stopped 1 year ahead of expectation in February, and therefore, due to overwhelming efficacy of rivaroxaban, which is an oral anticoagulant, 2.5 milligram BD plus aspirin. So what they tested was rivaroxaban, which is an oral anticoagulant plus aspirin, rivaroxaban 5 milligram alone or aspirin alone. These 3 arms were tested in the chronic patients, whether they will have acute event or not. And they had to stop the study 1 year ahead of expectation because of the overwhelming efficacy of rivaroxaban plus 2.5 milligram plus aspirin arm, and this arm was found to be very important, and therefore the vascular dosage of rivaroxaban and aspirin has significantly reduced CV death, stroke or MI. The vascular dose of rivaroxaban and aspirin significantly reduced secondary events also, and therefore COMPASS trial proved beyond efficacy that, of course, you will need to have rivaroxaban in addition to aspirin. Similarly, they had also a sub-analysis of the trial in chronic CAD plus PAD, and the curve separated at the early stage. And the vascular dose of rivaroxaban plus aspirin reduced the risk of major amputation and peripheral vascular disease, and in 7 out of 10 patients who otherwise might have lost a limb. And if you add this, so recommendation for event protection is that you have to add our oral anticoagulant, which is 2.5 milligram rivaroxaban over this. Coming on to the PCI and medical clinical data, PCI means percutaneous coronary intervention, angioplasty, plus of course medical therapy in chronic coronary syndrome. The trial has shown, especially the trial which was actually Courage trial. Courage trial was published in New England Journal of Medicine, about few, I would not say very recent, but it was still a hot topic to discuss. And the Courage trial patients were randomized to receive either PCI plus medical therapy or medical therapy alone. Very important trial. Medical therapy means all the medicines versus PCI plus medicine. So there was no significant difference in mortality was observed at any time. It was also found that whichever was the two treatment regimen was given, the mortality of the patient began to be mildly higher than that of normal population only 6 years after the start of the treatment. That means for 6 years there was no. Ischemia trial, initially conservative or invasive therapy for stable coronary artery disease, and this showed the strength and limitation, courage and trial. But I would like to tell you that ischemia trial and courage trial, there were only 21% of patient conservative group having revascularization. As a result of recruitment challenges, sample was reduced to 5,000. And secondly, there was high proportion of patients who had mild symptoms only, not severe symptoms. They excluded the patient of class 4 angina, and randomization of angiography was screened only in 3071 patients out of 35,000 patients. Patients did not reflect contemporary practice, and most of the patients did not receive drug-eluting stents. There was the limitation. So because of this limitation, there was no major advantage seen in both the trials of PCI, that means angioplasty plus medical therapy versus medical therapy alone. So this short term has shown that long-term clinical benefit of PCI over and above OMT and CCS, and the PCI treatment in coronary syndrome does not provide any long-term clinical benefit. This was actually the conclusion from these meta-analysis also. So what are the guideline recommendations? AHA says that, so my conclusion, coming to conclusion, all stable patients may not be completely stable. As we have seen that 20% will become unstable, and therefore you just cannot depend upon medical therapy. You have to do coronary angiography and see whether there is a critical stenosis which will require angioplasty. PCI has become a widely used and highly effective in treatment of stable CAD. Advancement of past 2 decades have led to improved short-term survival rates, reduced heart attack concurrence, and decreased need for repeat procedures. The choice between PCI means angioplasty again, bypass surgery and medical therapy depends on patient characteristics and the complexity of CAD lesion evaluated over the syntax score after doing angiography. PCI may be more suitable for single vessel, less complex left main coronary artery disease, diabetic, and those at high surgical patients. PCI has shown potential in lowering the risk of certain outcomes compared to medical therapy, such as combined risk of all-cause mortality, MI, revascularization, hospital admission, and stroke. This is very important. PCI has shown potential in lowering the risk of certain outcomes compared to medical therapy alone, such as combined risk of all-cause mortality, MI, revascularization. Future direction PCI for managing stable CAD after promising opportunity for improving patient outcome. And that future advancement includes health status outcomes, advancement in PCI techniques, innovation in device technology, personalized medicine through genetic testing, exploring combination therapy, and comparing this. These future directions require a concomitant to evidence-based practice and continuous research to achieve the best possible patient outcome. Finally, guidelines do guide you but does not impose upon the treating cardiologist. All the cardiologists or physicians, they should know guidelines, but they should not be completely directed. Every patient is different. Every patient you require a different approach, and one has to take the best decision in the best interest of the patient. So this is our talk about this. And can we have the scientific program? Any comment from Dr. Kundu?
Thank you. Thank you, Dr. Gupta. Excellent talk. This topic has been debated in many of the conferences. I think Vivek himself feels that despite optimal medical treatment, angiography has to be done, and then decide whether the optimal management has to continue or we have to do some intervention. Am I correct, Dr. Gupta?
Yeah, this is what I'm saying, that we should not miss out coronary angiography. I have seen many patients who have been advised coronary angiography and they avoid for several reasons. The most important reason is apprehension. Kuch nikal na aaye. And that should be avoided approach, because prevention is better than, of course, than facing the problems and facing the music. So optimal medical therapy is good if you start having even minor symptoms which are unstable, causing some stability. For example, a patient who is walking for 10 minutes and then having angina, now he starts having angina after 5 minutes. For example, he starts having angina while taking shower. For example, he starts having chest pain after the food, which is postprandial angina. These are the symptoms which cannot be missed out. If you have such symptoms, even the patient who was chronically okay requires coronary angiography. So you should tell all your patients, if advised, angiography is must. Many times we see that these patients, chronic patients, will have a left main disease and with a plaque rupture and sudden death. You have seen that many patients have died during this last COVID. After COVID, vaccines were also given. Why the vaccination patients are dying. So this is because the plaque ruptures. So if we have not only stent reduces the symptom, it also stabilizes the plaque. So I would really recommend this. Before we go on to the next lecture, we will have a video, because Dr. Mukesh Goyal was supposed to talk on heart transplantation. He's very busy in Apollo. He said he will be a little late. And Dr. Pandey will talk about the caring of the legs. So we will have a talk of the president of CSI, a recent talk which will be future of interventional care. Very important talk before lecture. I think that will be very useful. Let me just see, I have this talk here. You listen to this talk. This is about 20 minutes talk, but this will tell what he is speaking about, what will be the future of cardiology or interventional cardiology after 25 years. So he is going step by step and very nicely prepared talk. And he will be online because he could not come. 30th December was a wrong date. Many people didn't want to travel, and therefore we would like to talk about this future of cardiology or interventional cardiology with artificial intelligence, with so many things coming up, of how the patient will be treated after 25 years. So let's connect this video. This was actually, I have taken from the CSI. It's a presidential oration by Dr. Vijay Bang, who is in Leelavata Hospital.
I'm very